I know that Laura here, I was surprised when I saw her name because I said, I know that name. And then I realized that our clinic and Silverado have a special relationship in that we do a lot of things for each other. And so I was really glad to see Laura and Leah, who is also here to help with Laura on the presentation. And tonight's presentation is called Dementia 101. That's a big problem in our society here with the aging population. And I know these people here deal with it on a first-hand basis. And so listen up and ask some good questions because they know what they're talking about. So with that, I'm going to hand the floor over to you guys.
All right, great, thank you. Well, thank you all for having us. Thank you, Jessica and Christy, for inviting us. A lot of you probably know quite a few people, especially in your work, that have some kind of dementia. So I don't want to stand up here and bore you by any means or kind of assume that you don't know much about dementia. So if I'm kind of, it's going one in the ear and out the other, just say, yep, we got that part, move on kind of a thing. So I'm perfectly fine with that. Because we speak in front of a multitude of different groups, church groups, physicians, families, of course. So everyone has varying degrees of knowledge of dementia. So we thought we would start off tonight with just kind of going back to the basics, kind of doing that good old Dementia 101. I will go through what are the most common types of dementias that are out there. And we'll talk a little bit about some of the changes that happen in the brain when somebody has dementia. Some of the things that we see as symptoms when somebody is starting to show symptoms of dementia as well. But please feel free as we are kind of going through this to just stop and ask a question at any time. I'm not super fancy. I don't need to wait until the very end to ask questions by any means. I want this to be interactive and helpful for you so that you can take whatever it is away. So what I usually like to start off with are some statistics because there is a reason, as we mentioned, that we're talking about dementia. We certainly know that there are a large number of seniors and unfortunately some younger folks who are also starting to show signs and symptoms of dementia. Right now we believe that about 5.3 million people in the United States have Alzheimer's disease. We actually believe too that number is expected to get to about 16 million by 2050. And why do you think that is? Why such a huge spike? Baby boomers. Jessica got it. So our baby boomers, about, I think it was 2013, the oldest of our baby boomers turned 65. And as we know, age truly is our #1 risk factor for dementia. We know that the older that we get, the higher our risk and chance of actually having dementia as well. We actually, frighteningly, will say that we think that about 1 in 8 baby boomers will actually get Alzheimer's disease. So it's a huge population. It's a huge group of people. If any of you baby boomers are in the room, I'm not trying to say anything negative, but a lot of our baby boomers lived, through the 60s. They had a lot of fun. They're actually one of our more heavier, more obese population as well. So they've done a lot of things throughout the years that haven't been really, really great for their brain. And unfortunately, we see some of these risk factors that just start to kind of pile up and pile up and pile up, causing them to be at higher risk for getting dementia. So what is dementia? How would you explain? A patient walks up to you and says, well, what's dementia? How would you explain it?
I'm not sure this is accurate. It's a disease process of the brain, which basically is a disconnect of neurons.
Okay. Sure. What else? What else do you think?
I know where they get confused on like time of day to time of year?
Yeah, absolutely. Some moments are better than others too, right? In the morning, our memory is generally much better for all of us in the morning.
Someone totally different than
It
who they
can.
are?
Yeah, some
Like
personality
even a different
changes.
name?
Not usually.
Oh, okay.
Not usually. But it can be more personality type changes. Or maybe if they were called a nickname when they were a child, they might revert to that name, but it's usually a name they know and
They know,
recognize.
okay.
Yeah. Anything else that you think of with dementia? So I think the hard part is that in our society, we've kind of lumped Alzheimer's and dementia together, right? When all in true actuality, they're actually very different from each other. It's almost like saying dementia is this umbrella term, this group of symptoms that we have where someone starts to have confusion, memory loss, personality changes, changes in their communication and cognition, so much so that it affects their daily life. Right? Because we all have moments and lapses of forgetfulness, right? Anybody walk in a room and not remember why you walked in, right? We all do it. Or, what was I just telling you? We all have certainly those moments of forgetfulness, but usually later it comes back, right? We usually always joke that you can't remember somebody's name. Always, never fails at 2 a.m. It comes right back to you, right? So the idea is it has to be so much so that it truly disrupts your daily life, okay? And so being that umbrella term that it is, there's several different diseases that fall under that dementia umbrella that cause those symptoms of dementia. I usually will liken it to the difference between a flower and a rose, right? A rose is a flower, right? But it's a very specific type of flower. Whereas dementia and Alzheimer's kind of fall into that. Dementia is kind of this global term we use. Alzheimer's disease is a very specific disease process that's causing these dementia symptoms. Make sense? So the hard part is we have many families who bring their loved ones in to see a physician, and they're noticing some changes. Very oftentimes, we can't tell just from looking at somebody what kind of disease that they have, right? And so very often, most physicians will say, well, it sure looks like dementia, and kind of leaves it at that, okay? Problem with that is that's almost like going to your doctor and they say, I'm so sorry, you have cancer, but I don't know what kind. Because there's a huge difference between breast cancer and lymphoma or skin cancer, right? All of those are very different. Yes, they're all cancer, but they're all very different from each other. And so same with these other types of diseases that are causing the type of dementia. And treatments vary as well from dementia to dementia. So we actually think there are upwards of about 75 different diseases that actually cause dementia. So it's hard when you just get that kind of blanket, it's dementia. Now in one sense we kind of get that. Leah and I talk to families every day. We probably, if we had a nickel for every time someone said, oh no, it's not Alzheimer's, it's just dementia, we'd be millionaires at this point, right? It's almost like dementia is just a lot easier to take, right? Dementia is just kind of something that happens when you get older. But Alzheimer's, that seems a lot more difficult for families to understand the changes that are happening. So that dementia diagnosis for them is a little bit easier. It's not as hard. They don't really feel like it's, oh my gosh, the world is coming to an end. Even though it's the same symptoms, right? So the hard part is getting more physicians to really get more diagnostic tests put together to maybe figure out, hopefully, as close as we can get, to figuring out exactly what kind of disease this person has that's causing the dementia. And the reason we also like to do that is because about 10% of the time, it actually can be what we call a reversible dementia. These are things that are changes that are happening within the body that are creating dementia-like symptoms, whereas we can actually treat what's happening in the body and the dementia will actually go away. Any of you have probably seen an elderly person who has no food in their refrigerator. They really haven't been eating much lately, or maybe unfortunately bad food that's in their refrigerator. They come to you, they're truly malnourished. They really don't have, vitamin B12 in their system. They're just not getting what they need. And they actually are much, much more confused. We get some good nutrition in them, we get their vitamins and minerals up, we actually see their cognition starts to get much better. Yeah?
Would alcoholism fall in that category?
Yes and no. Yes, because it can potentially be a reversible dementia if it hasn't been going on for a very long time. But the longer that somebody actually is consuming alcohol, it actually can do irreversible damage to the brain. Yeah, that's a very good question. So those are some of the things we want to kind of check off the list first. Is it one of these reversible dementias? Because could you imagine if this was one of your loved ones and the doctor says, yep, it's dementia, here's Aricept, and really it's a vitamin B12 deficiency, right? Or a hypothyroidism that could be causing this memory impairment. So we want to really kind of dive a little bit deeper and just make sure it's not one of these reversible types of dementias. Many of you probably see it very firsthand, why can't I speak right now? I might. Polypharmacy, right? Somebody who's taking so many medications. I mean, they come in and it's, 17 pages of medications that they're taking. Just that in itself can cause some, memory loss type symptoms as well. So maybe being able to kind of cut down a little bit on their meds might certainly help too. So let's go back to the irreversible types of dementias. So in those irreversible types, as I mentioned, there's over about 75 different types, but there is really kind of 5 most common forms of dementia that we see. Alzheimer's disease, of course, is the most common type of dementia that we see. We'll talk about Alzheimer's quite a bit in just a moment. But I want to go over the other kind of top 4 ones as well. So one I want to talk about in particular is called frontotemporal dementia. Any of you ever heard that term or worked with somebody? So I'm excited, I see like brain pictures and stuff around. So. The frontotemporal dementia is one that is very, very specific to the frontal and temporal lobes of the brain. So no other part of the brain really gets affected by the disease other than those 2 lobes. And so with frontotemporal dementia, or sometimes you might even hear it called Pick's disease. All these doctors that name these like horrific diseases after themselves, but Dr. Pick found the first person who had this frontotemporal dementia. And it generally happens in younger men. Certainly can be women as well, but much more common in younger men, 50s, 60s age men. It is a very fast progressing disease. We generally will say someone will live anywhere from about 2 to 4 years upon diagnosis, so it's pretty fast moving. The hard part with frontotemporal dementia is it's a lot of difficult behaviors. Because as you probably know, the frontal lobe of our brain is our personality. It has a really, really important job of having what's called inhibitions. That thing that is in our brain that says, God, I would love to do this, but that'd be so inappropriate, right? That part of the brain starts to become affected, and so that inhibition starts to fall away. We start to see super manic episodes of disinhibition. And for the men in the group, I'm sorry to say, single you out here, but of course these are younger men, these are usually sexually active men, tend to be a lot of really strong, inappropriate sexual behaviors in most of these residents, or most of these patients. But again, it can happen in women as well. One thing that we see quite often is that one of the first symptoms of frontotemporal dementia is actually not memory. It's more of the personality changes. We definitely see with frontotemporal dementia a huge spike in an urge for sugar. We've actually have had a resident who lived in our Silverado community, a woman who had frontotemporal dementia, and we literally couldn't have like the oatmeal bar sitting out because she would eat the entire bowl of brown sugar.
Oh, wow.
She just would literally eat the entire thing. Her brain just was starving and craving for sugar. So something that we see quite often with frontotemporal dementia. Another one is Lewy body dementia. Anybody familiar with that one?
I've heard of it.
You've heard of it? Yeah. So Lewy body dementia is it is a dementia that, again, one of the primary symptoms is not memory impairment, but it is actually more hallucinations. So these are oftentimes pretty specific visual hallucinations. Most oftentimes, too, they're not frightening hallucinations. They're kind of more matter-of-fact hallucinations. I use the example all the time of a doctor friend of mine and his patient who had Lewy body dementia. And the very first time that this doctor had met with this patient, the patient got very angry with the doctor as he was just being so incredibly rude because he did not say hello to his Japanese samurai who came to the appointment with them. This gentleman had been a Japanese historian. That was his career. And so he would really get really angry with the doctor, like, hello, not alone here, don't be rude. And so to him, I mean, he truly had this Japanese samurai who would just follow him everywhere, and it was, very matter of fact. It wasn't like, oh my gosh, the samurai is following me, But yeah, the hallucinations are usually real primary with Lewy body dementia as well. And then with vascular dementia, and we actually think vascular dementia is the second most common type of dementia that we have. These are unfortunately folks who have had multiple strokes, possibly multiple TIAs or even heart attacks, and have had blood flow loss to the brain, which has caused some permanent damage vascularly for these individuals, which then causes an irreversible dementia for them. Vascular dementia definitely does show as a memory impairment first and foremost. One thing that we definitely see with vascular dementia, if you think of Alzheimer's disease, it's kind of this downward slope, right, of progression, right? Over time, they kind of slowly but surely change. With vascular dementia, it's very much a step-like process. So they're here, they had a really bad time, then they're all the way down here, and then they kind of plateau, and then they're down here again. And so it's very much a step process. It's not kind of your gradual progressive. So you might have somebody come to one appointment, and in 3 months they come back, and it's totally different person just because they've kind of moved down maybe a step or two in that time frame. But definitely focused on heart health, brain health in particular for the vascular dementia. We actually think the vascular dementia is the most preventable type of dementia that we have. Again, more heart healthy foods, obesity, high blood pressure, all of those put us at very, very high risk for the vascular dementia. And then the last one I'll talk about before I talk about Alzheimer's is Parkinson's dementia. You all probably know what Parkinson's is. A large number of residents or patients who have Parkinson's actually do not get dementia. It's a small minority who actually start to show more dementia-like symptoms over time as the Parkinson's is progressing. Parkinson's is hard, obviously, for anybody, but adding dementia to it, a lot of times you see a lot of falls in Parkinson's dementia, my brain doesn't remember that I can't walk as well as I used to, and of course you all know that disconnect between my brain saying, yep, we're moving, but the body not moving with it. And so, Parkinson's dementia is a tough one because you do tend to see a little bit more bodily injuries simply because of the Parkinson's disease.
So is there a big difference between the Lewy body dementia and the Parkinson's dementia?
There is. That's a good point. So Lewy body dementia, a lot of times people will say, is kind of a combination of both Parkinson's and Alzheimer's disease at the same time. The hard part is it's kind of the whole chicken and the egg thing. So if somebody has Parkinsonian symptoms and more memory loss symptoms come up later, it's very likely Parkinson's dementia. If we do it the other way around, more memory symptoms, and later on in the disease process, we start seeing more of the resting tremors, more Parkinsonian symptoms, it's very likely it's actually Lewy body. The hard part is a lot of us don't maybe recognize which one actually came first, unless it's a really drastic amount of time between. Yeah?
So, your patients, are they always diagnosed with what type of dementia they have before they arrive at your door? Or is it something that comes as time goes by?
I would say no, majority do not. Most come with the blanket dementia diagnosis. And I would probably guess, gosh, large majority, maybe 75, 80%, don't ever know what type of dementia they have.
Yeah, because it's hard to diagnose.
Yeah, yeah.
If they've had like a stroke or something like that, then we can pretty much say, well, I bet you this is probably, more vascular, obviously, or alcoholism in their past or something like that. But from a doctor, it's pretty much dementia.
Yeah, and I think sometimes we try to do that blanket dementia diagnosis. And probably most of you, if you have any patient that comes to you that has dementia, probably seen a prescription for Aricept, right? Aricept is the most common medication that is prescribed for somebody with memory impairment. The hard part is it's not a one-size-fits-all. In fact, somebody who truly has Lewy body disease can actually cause the symptoms to worsen significantly, and that's irreversible. So again, it's, no treatment option is going to be, across the board, it's going to work for everybody because it does really show us how important it is to find out exactly what type of dementia the person has.
Usually in that situation, the diagnosis comes from ruling out things, correct?
Yes. Yeah.
Because there's no test, you can say, okay, you got this.
Right. It would be easy, right? If we could just do a blood test and we say, yep, looks like Alzheimer's, right? It would be much easier that way. I mean, there are some dementias that are like that. Huntington's disease is one. We can actually take a blood test and see that they are genetically at risk for Huntington's disease. Yeah.
So if there's no way to test for specifically like Lewy body,
Yes.
have they discovered Lewy body on autopsies?
Yes, from an autopsy.
Okay.
Yes.
So there's nothing okay.
Yeah. Yeah. Yeah.
That's when it's identified. So.
Exactly. Dr. Lewy
Yeah.
found in doing an autopsy of the brain, he called them little Lewy bodies in the brain, which look different than Alzheimer's plaques in the brain, and so that's why it's called Lewy body dementia.
So that's when it's definitive.
Yep.
Okay.
Yeah.
Thank you.
Did you have a question too?
Well, what I was wondering was like with the one with the multiple medications, are there certain medications that you guys look at and go, well, we need to see if this is causing this, or is it just when you see that they have like 3 pages deep that you're like, we need to sort some of this stuff out and see what we can eliminate and see what happens?
Yeah, for the most part, what we try to work on are the non-necessary medications. I mean, you would be amazed at how many of our, I had a 104-year-old resident who had, 3 pages of vitamins she was taking. Like, let's really be honest. She's 104, and I don't mean that that to sound crass in any way. I'm just like, that's a lot of vitamins for her to be taking. And over time, you know, our swallowing starts to become difficult. And for this poor, you know, 104-year-old lady to swallow. So we're going to really rule out non-necessary medications first. What we tend to find at Silverado is that the majority of the residents who come to us who are on a multitude of medications have lived at another skilled nursing or assisted living facility. And so very often the antipsychotic medications are used really heavily because, you know, this person is exit seeking, they're trying to go home. So let's put them on a medication so that we can stop that. Well, that's not the way we look at things. We want to look at things from a more holistic point of view of instead of saying, no, take a medication and go lay down, we'd rather say, tell me about your home. And we talk about it and we'd be able to reduce some of those medications. Don't get me wrong, there are still some people out there who need a little bit of something, right? They have anxiety disorder. We definitely know depression and dementia go hand in hand with each other. Large percentage of our residents are on antidepressants, and we find that to be incredibly beneficial for them. But a lot of times if somebody is moving into our community, we're usually looking first at some of those antipsychotics. Yeah.
Is there anything in particular with a connection on any of these types of dementias with sundowners also?
Yes. So with Alzheimer's disease in particular, you definitely see quite a bit more sundowning. We definitely in Parkinson's, we'll see some changes in sundowning as well. The whole idea, of course, is very often it's getting towards, you know, later in the day. We actually can attribute a lot of the time some sundowning behaviors to exhaustion. Just as you and I are, you know, at 6 o'clock, I'm getting kind of tired. I've been up since whatever time this morning. Or even sometimes it's hunger or thirst that can cause some of the sundowning behaviors that we see too. I always use the example, I don't know about you, but 3 o'clock, I'm like, where's the chips, right? So I'm looking for something to